Hello everyone, welcome to today's Indians program. Today is the last session of brain stimulation module we are running. Today we have with us Dr. Shyam Sundar, who is additional professor of psychiatry and consultant at OCD clinic here in Bangalore. He's interested both in obsessive compulsive disorder, bipolar disorders, and also in DBS, RTMS, and ECT. He has won fellowships in mood disorders at Vancouver and DBT Wellcome Trust Intermediate Fellowship in 2019. Welcome you, sir.
Good afternoon, everyone. Okay, thank you for attending this talk in the midst of all this confusion. So today we'll be discussing about invasive neuromodulation for psychiatric disorders. In this, I'll be discussing primarily about deep brain stimulation and vagus nerve stimulation. So when we speak about invasive neuromodulation techniques, I use the term specifically neuromodulation instead of neurostimulation because one of the most commonly used neuromodulation technique is ablative neurosurgery, where we create lesion in a particular part of the brain, which is the most common and oldest invasive surgical treatment for psychiatric disorders. And apart from that, we have deep brain stimulation and vagus nerve stimulation. These two are the things we'll be discussing in this talk. And the fourth one is epidural cortical stimulation, which is a new technique that has come up. And I'll not be focusing on that much because there is only 1 or 2 studies on that and not much has been done so far. That's just an emerging stimulation where basically you insert an electrode into the cortical surface and then you stimulate them. Usually it's done in the frontal lobe or sort of things and for depression. So we'll be focusing primarily on deep brain stimulation and vagus nerve stimulation. And when I say vagus nerve stimulation, there are 2 types of vagus nerve stimulation. One is the invasive one that has been used for quite a few years. And that is, we'll be discussing about that aspect of it. There is another non-invasive vagus nerve stimulation where transcutaneous vagus nerve stimulation, where the stimulation is done through the auricular branch and where the electrodes are placed on the skin. I will not be discussing about that aspect because there are only very few studies, and the primary mandate is here to discuss about invasive neuromodulation. Okay, to give a brief back about psychiatric disorders, invasive surgical treatment for psychiatric disorders, we can divide the surgical treatment into 4 eras. It started sometimes in the 1930s onwards when prefrontal leucotomy or lobotomy was given. And this was the procedure where white matter tracts connecting the cortical structures and the subcortical structures were severed through various indiscriminate procedures. Basically, these procedures came into disrepute because of the increasing side effects, primarily in terms of long-term personality changes. But later in the 1960s, people started, after the advent of imaging and improved neurosurgical techniques, particularly the advent of what is known as stereotactic surgery, where you're able to produce lesions accurately in a particular part of the brain. Along with it, we also started understanding the neurobiology of psychiatric disorders to a better extent. So, in that background, 2 primary procedures, cingulotomy and capsulotomy, people started using these 2 techniques. So, and then the third major breakthrough came in 1999, basically when deep brain stimulation was first tried in psychiatric disorders, that is in OCD. And apart from that, vagus nerve stimulation was also tried in the early 2000s. So that is the third epoch. I'll be discussing primarily about this particular aspect and the current evidence on these aspects. And the fourth epoch we can talk about is the recent developments where if we have time, we'll be discussing about this aspect. Basically now better targeting for deep brain stimulation and more advanced techniques called closed loop techniques have been formulated. Yeah. So, So contemporary neuropsychiatric procedures are based on 3 particular aspects. 3 advances have happened. One, as I said, stereotactic surgery and image guidance. Basically, like we can take the MRI of the person, and through that we'll be able to target the surgery in a better way. And the other major advance happened in ablative surgery, where gamma knife radiosurgery, and the recently this one has come up, magnetic resonance guided focus ultrasound. These 2 surgeries can happen without craniotomy. So ablation of a particular deep brain structure can be done without opening the skull at all. And the third most important advance is DBS and VNS. And the other major thing that has come recently is careful selection of patients. As I said earlier, surgery was tried a bit indiscriminately now because of ethical reasons. Currently, only people with chronic treatment refractory and severe psychiatric disorders are allowed to be allowed to undergo surgery. I'll be coming to this in the future in the other slides. And the third major thing that has happened in the recent times is network model of psychiatric disorders. Earlier, there was something called as a modular model where psychiatric disorders were considered to be originating from one particular part of the brain, say frontal lobe or something like that. But now it is saying that more than a particular part of the brain, the network connecting various parts of the brain are more important in modulating various cognitive and other emotional functions, and probably psychiatric disorders also. So if you target anywhere among these dysfunctional networks, you might be able to produce some change in psychiatric disorders. If you, for example, if you charge in the superficial structures, you can do it through non-invasive stimulation like RTMS or TDCS. In deeper structures, we usually target through neurosurgery. The advantage of targeting the deeper structure is that the superficial structures are generally more diffuse. So, but in deeper structures, multiple superficial structures, cortical structures can connect to one particular deeper structure, what we call a subcortical nuclei. So, targeting that particular area will have more diffuse action in psychiatric disorders. That is the advantage of invasive neuromodulation, but the disadvantage is that, of course, it is invasive. So before going to the individual techniques, I'll just speak about the broad guidelines. This is a recent guidelines which was formulated last year for neurosurgical interventions for psychiatric disorders. As I said, that indication, it's only for chronic, severe, and treatment refractory disorders. And as of now, the evidence is there only for OCD, depression, and Tourette syndrome. So, and the surgical target should be based on available literature, and there should be required expertise to conduct the neurosurgery. There's a need for a multidisciplinary team with neurosurgeons and follow-up, and close follow-up is also required for these neurosurgical techniques. And another important aspect is informed consent. How to take the informed consent. All these issues are discussed in the guidelines. I will not go in detail about these aspects. So this is an international guidelines which summarizes what is the evidence for psychiatric disorders. This was published in 2014. It says that invasive surgeries are supported by level 2 evidence only in treatment refractory OCD and OCD and major depressive disorder. And one more important thing is that before undertaking surgery, you should remember that surgery is just one aspect of a comprehensive treatment program. It's not a standalone treatment. It's not curative. It's just one aspect of the treatment. And even after surgery, it's just an augmenting procedure. Other treatments like medications and if as required, psychotherapy might have also has to be continued in follow-up. And a bit about the legal aspect also. The recent Mental Health Care Act has said that psychosurgery should not be performed unless you take an informed consent from a patient, and also you should get approval from the concerned board, which means the mental health review board of the particular locality. So only after these two aspects are done, you can post a patient for invasive procedures for psychiatric disorders. I'll just focus just on one slide on ablative surgery. After that, we'll be going to DBS because everything started with this. So there are 4 ablative procedures that are generally discussed. One is anterior capsulotomy, where the target is the anterior limb of the internal capsule, which targets where the lesion is placed on the fibers connecting the frontal cortex and the basal ganglia. So most psychiatric disorders were said to be because of the dysfunction in these circuitry. So that was one procedure that has been commonly practiced. And this procedure is primarily currently being used in OCD. And anterior cingulotomy is the second commonly used procedure, where the lesions are produced in the anterior dorsal anterior cingulate cortex and the adjacent cingulum bundle. So in this, this is commonly practiced in patients with major depressive disorder, treatment refractory major depressive disorder, but also in some centers, especially in certain centers in US, they practice it for OCD also. And the third procedure, subchordic tracheotomy, is not commonly practiced nowadays, but it is sometimes practiced in people, especially with depression, for whom cingulotomy alone is not effective. Sometimes you add subchordic tracheotomy, which is sometimes known as limbic leucotomy, as an additional add-on procedure. So with this, we'll be going to deep brain stimulation. Yeah, coming to deep brain stimulation. Deep brain stimulation is, as you know, there are electrodes are inserted into deep subcortical, usually subcortical structures of the brain, and yeah, it has there are 3 steps involved in deep brain stimulation surgery. The first is insertion of electrodes, where an electrode is inserted into the deeper structure, and in this one, it's inserted into the subthalamic nucleus. This procedure is usually done under local anesthesia. A craniotomy is required, but since the brain doesn't have any pain receptors, it can be done under local anesthesia. As I said, the imaging is, the targeting is done under stereotactic guidance, where a frame is attached to the person's scalp, and with the help of the image, you target a particular structure. And along with it, you will also be able to record electrophysiological activity from a particular part of the brain, through which you will come to know whether we reached a particular structure or not. And immediately after insertion of the electrodes, we also do a sort of post-operative imaging or intraoperative imaging. This is a CM imaging which has been done in implants, where to confirm the position of the electrodes. So, and along with it, during this part of the surgery, intraoperatively, the electrodes can be stimulated to see whether there are any acute effects or side effects. If such things are there, then the position of the electrodes can be changed or removed. And another important thing to notice in deep brain stimulation electrode is that usually this is the electrode that is inserted. This is the tip of the electrode, where there are usually 4 contacts. We have a sort of flexibility to keep any of these contacts on and the other contacts off, or we can keep even 2 contacts on and the other 2 contacts off. So all these sort of flexibilities is possible in deep brain stimulation. That will be the first step. The second step is the implantation of a pacemaker or implanted pulse generator. This is usually placed in the chest of the patient subcutaneously, and it is usually done as a separate procedure under general anesthesia. And it might be done on the same day, or in a few centers they do it after a few days. And this is connected subcutaneously to the electrodes, and this generates the pulse through which we activate a particular part of the brain. And there are 2 types of batteries that are available. Earlier batteries used to be non-rechargeable batteries. That is, once you insert the battery, you need not worry about it. It will keep on stimulating the brain. And the battery used to get exhausted after a few years, depending on how much stimulation you give. In movement disorders and neurological disorders, it's up to 5 years. But in certain psychiatric disorders, it gets over in 2 years. The advantage is that it's less cumbersome. The cost is also less. The one-time cost is less. The disadvantage is that you had to replace the battery after the battery gets exhausted, and you had to perform another surgery. There is another new development, that is rechargeable batteries, where you can recharge the battery periodically. Usually once in 1 or 2 days, you recharge the battery. The advantage is that it may not be replaced that frequently. And the disadvantage is that it's more expensive in short term. It's almost double the cost. If this one costs around 5 lakhs, this costs around 10 to 12 lakhs. So it's quite expensive in short term. The other disadvantage is that like you should always be worried about whether the battery is charged or not. Sometimes the battery goes off suddenly, and the person, especially in people with mood disorders, it's been seen that there's a sudden worsening of mood, and with even suicidal ideations that has happened. So that is one disadvantage. So any of these 2 things, as per the patient's preference, can be tried. And the third step, after these 2 things are done, the third step is the programming. The programming is usually done by a specialist who has experience in programming, and the person comes repeatedly to the center to program. Various things can be programmed. As I said, you can keep 1 of 2 contacts active, the others inactive, and various other aspects of the electrical stimulation like polarity, amplitude, frequency, and pulse duration. These things can be modulated to provide the best possible parameters. So how do you choose the best possible parameters? In many neurological disorders, it's quite easy because the effect is immediate, especially in Parkinson's disease. You adjust the parameters and see whether there is an immediate improvement in tremors or not, or rigidity or not. But in psychiatry, unfortunately, the effect takes quite some time. It usually takes 3 to 6 months to be visible. So usually the programming is based on existing previous evidence, whatever we have seen in literature, and also it's based on tolerability to see whether there are any acute side effects or not, and some acute effects. For example, some people have seen that when you're targeting the nucleus accumbens, an immediate laughter response suggests that you're at the right target. The patient has more chance of improvement if there's an immediate laughter response, if their stimulation leads to laugh in the nucleus accumbens. So based on such parameters, you choose the best possible parameters. So this usually takes some time. So even after surgery, it may take 3 to 6 months to find the best possible parameters. So how does DBS work? Even in neurological disorders and also in psychiatric disorders, we are not sure exactly how it works. Various different mechanisms have been postulated. The most commonly discussed earlier was the functional lesion. It produces very high frequency stimulation, produces a functional lesion in a particular brain tissue. So the activity of the particular region decreases. That is one particular hypothesis that was commonly discussed. But apart from that, there were a lot of other mechanisms that were discussed. It can cause changes in neurotransmitters. It can cause some changes in distant parts of the brain. But currently, the most commonly discussed hypothesis is that in the dysfunctional pathological circuits of the brain, generally the brain has a normal oscillation. In the dysfunctional circuit in psychiatric disorders, the oscillations go haywire. So in DBS, this somehow corrects this dysfunctional oscillations and makes it oscillate in a more regular rhythm. So what are the advantages of DBS compared to ablational neurosurgery? The advantage is that it's a reversible neuromodulation. Side effects are hence reversible, at least some side effects. And also, as you said, you can adjust the stimulator to produce the best possible stimulation and to reduce side effects. And you can, to some extent, change stimulation sites by keeping one contact active or the other one active. The disadvantage is that it is quite expensive compared to ablative surgery. For example, at NIMANS, ablative surgery might cost around 1 lakh, but DBS might cost around 5 to 6 lakhs. And you have to change the batteries periodically, and there's a need for a highly skilled manpower for intensive monitoring and follow-up programming also. And it's quite invasive compared to ablative surgery, where some craniotomy is not required. Yeah. So I'll just, before going into the evidence for DBS in psychiatric disorders, I'll just be discussing about certain aspects of DBS studies in psychiatry. The advantage with DBS compared to ablative surgery is that where you can do a sham stimulation, you can insert the electrode, you can keep the battery off. The person doesn't know whether the battery is on or off. So based on that, you can easily, we'll be able to do a sham control trial. And also the another advantage is that the person can be his or her own control. That is, you keep the stimulation on for 3 months, and then you keep the stimulation off for another 3 months. So you'll come to know which work better. And the patient and even the rater can be kept blind to the whether the stimulation was on or off. That is the advantage of DBS. But there are some challenges, especially in psychiatric disorders. In psychiatric disorders, as it has been seen that the improvement doesn't happen immediately. It takes around 6 to 12 months for the improvement to set in. So to give a sham stimulation for such long duration is a challenge. And the other effect is carryover effect, where, for example, as I said, if you keep the stimulation on, and if you keep the stimulation off, there will be a carryover effect. Because of 3 months of stimulation, the effect might not go away immediately. It may take 1 or 2 months for the effect to go. So generally, for such studies, a washout period is required, where between the on and off stimulation, at least 15 days to 1 month of washout period is required. And the third important aspect is the insertion effect, where just because you are doing surgery, there may be a micro lesion, a small lesion might be there, which might itself lead to improvement, not necessarily the stimulation which you're giving later. But this effect is generally seen to be transient, and it usually goes away after some time. So with this background, I'll be discussing about the evidence for DBS in two disorders, primarily depression and OCD. So I'll start with OCD. OCD was the first disorder in which DBS was used. It was the first study was done in 1919 by Bart Newton from Sweden. So the target used was anterior limb of internal capsule. This was based on the hypothesis that ablative surgery targeting anterior limb of internal capsule was effective. So they tried the same thing and they found it to be effective in a few patients. And over the past 20 years, multiple studies have found, and even there is a guideline for use of DBS in OCD, and there are multiple RCTs are also there, which I'll be discussing now. So what is the role of surgical interventions in OCD? The indication, as I said, it's severe, chronic, and disabling and treatment refractory illness. Only they are allowed to undergo surgery. And as it's generally discussed in OCD, there are different cortico-striato-thalamocortical circuits which are found to be dysfunctional in OCD. These circuits start from a particular region in the cortex and they go to a particular region in the striatum and then to thalamus and to the cortex again. These are not single loops. There are multiple loops. There are multiple loops originating from different aspects of the cortex. And for example, there is one loop starting from orbitofrontal cortex, one from dorsolateral prefrontal cortex, and one from supplementary motor area. And all these loops are found to be partially segregated with some interconnections. And these interconnections are generally found in the subcortical structures. In the DBS, we tend to target in one of these loops. The primarily used things, I'll be talking about the target in the subsequent slides. And it has been seen that when DBS is given, there is a change in frontal activity in the, like after when you use functional imaging, it has been seen that there's change in activity in the frontostriatal circuits. Similar changes have been seen in multiple interventions for OCD, like SRS and CBT. So probably all these things work in the same way by modulating these frontocortico-thalamo-frontal circuits. So this is the selection criteria. This is taken from the clinical practice guidelines for OCD published in Indian Journal of Psychiatry, but most guidelines across the world use similar criteria for surgery where the patient needs to have very severe OCD, at least 28 in Y box, and the patient should have at least 5 years of illness, and patient should be found to be treatment refractory with at least 2 SSRIs, 1 clomipramine trial, at least 2 augmentation, 1 adequate CBT trial. Only if all these things have failed, you start the patient for surgery. These are relative contraindications. There are no hard and fast contraindications. These are relative contraindications because the DBS has not been studied in this population. But apart from that, there are no absolute contraindications. So these are the commonly used targets for DBS in OCD. There are multiple targets that have been displayed in this slide, but if you see, the earliest used one was anterior limb of internal capsule, and it was seen that when stimulating the anterior limb of internal capsule, many nearby areas, targeting many nearby areas might also be helpful. These areas include what is commonly known as ventral striatum, which includes the nucleus accumbens. So people found that targeting the nucleus accumbens might also be helpful. Later, people found that this bed nucleus of stria terminalis, which also lies very close to the internal capsule. So when you target this particular region, the internal capsule region, which is sometimes known as ventral capsule and ventral striatum, you might be targeting any of these 4 target regions. So depending on the amount of stimulation and which contact you keep active, any of these 4 regions can be kept active, can be stimulated. So sometimes this type of DBS is known as ventral capsule, ventral striatum, or striatal DBS. So this is one commonly used, this is the most commonly used target across centers. And the second commonly used target is subthalamic nucleus. This, this has been used in few centers, and I'll be coming to the evidence in the subsequent slides. There are 2 other recent targets, inferior thalamic peduncle and medial forebrain bundle, but there are very few studies, so I'll not be discussing about it. I'll be discussing about these 2 particular targets. As I said, these are the 4 different targets. Although we say these are 4 different targets, they are so close. As you can see in this, they are so close to each other. This particular part of the brain is the internal capsule. This is the ventral striatum or nucleus accumbens. So through DBS electrodes, when you insert into this particular region, you can keep both of them active. You can stimulate both internal capsule and nucleus accumbens, or one of them, depending on which contact you want to keep active. And similarly, the BNST, bed nucleus of striatum, is also somewhere close by, but these also can be stimulated by this by a similar trajectory. So, as I said, this has been the most commonly studied. I'll not be going into the individual studies. I'll be discussing about the largest study that has been done. This is a recent study that was published in 2020, where 70 patients were targeted with the DBS and over the internal capsule, and it found that around 50% of these 75% of 70 people were responders to treatment. That is, they had at least 35% reduction in white box, and at least 17% of them were at least partial responders. So the response was seen after 12 months. So generally in DBS for OCD also, it has been found that improvement happens after 3 to 6 months, but in some patients it can happen immediately also, like within a few weeks or months also. And there are a few control trials that are there in DBS or ventral capsule. I'll not be discussing about it. The second target which I spoke about is subthalamic nucleus. As I said, the striatothalamo-cortical circuitry, there are 3 pathways in this circuitry. One is the direct pathway, second is the indirect pathway, and third is the hyperdirect pathway. We need not go into the details, but generally the direct pathway is considered to be stimulatory. That is, increased activity in this pathway increase the activity in the cortex. The indirect pathway and hyperdirect pathway are inhibitory in nature, and both the indirect pathway and the hyperdirect pathway pass through the subthalamic nucleus. So in OCD, it has been hypothesized that there is an imbalance between the direct pathway and the indirect pathways. There is a hyperactivity in the direct pathway, and there's an hypoactivity in certain indirect pathways. So probably you're stimulating the subthalamic nucleus to counteract this imbalance. And it has been seen that there are various cognitive functions that are modulated by subthalamic nucleus, and and these cognitive functions have been found to be impaired in patients with OCD also. So targeting DBS over subthalamic nucleus might help in OCD by modulating these cognitive functions. This is another hypothesis, but yeah. So basically, although this is the mechanism, the rationale given for subthalamic nucleus, it was basically started because subthalamic nucleus is a commonly used target for Parkinson's disease. And when people with Parkinson's disease with comorbid OCD were started on DBS, it was found that their OCD symptoms also improved. Based on that, a French group started trying subthalamic nucleus for OCD. The difference is that the target in the subthalamic nucleus between OCD and Parkinson's disease is slightly different. You go more ventral in OCD, and you go slightly more posterior and dorsal in Parkinson's disease. Yeah. So as I said, the French group by Luc Mallet et al., they conducted a very well conducted randomized control trial, and you can see in this trial they inserted the electrodes, and for half the patients they kept the initial 3 months. This is the time when the electrodes were implanted. First 3 months they sort of did the programming and adjusted the stimulation parameters. And after that, in half the subjects, they kept the stimulation off, the other half on. And they gave a washout period. And after that, the patients for whom it was on, it was switched turned off. And the off group, it was turned on. So overall, it was found that, and the patients and the raters were blinded to the group in which they were. Overall, if you see in the Y-box score decreases whenever the stimulation is kept on, and it increases when the stimulation is kept off in both groups. And similar changes can be seen in the global assessment of functioning also. So based on this study, this is one of the well-corrected RCTs. Subthalamic nucleus DBS is considered to have the best evidence as of now, best quality of evidence, not the best evidence, best quality of evidence in OCD. Yeah, because it is a randomized control trial. Yeah, this is just another trial which we are planning to start in the near future. We have where we'll be recruiting patients for subthalamic nucleus DBS, and this yeah, so now I'll be going to the what is the overall evidence. It is just a meta-analysis of multiple studies for DBS and OCD, and it was found that if all the studies were compiled together, around 60% of patients, patients improve with DBS and OCD after around 6 months of treatment. So I spoke about two targets. One is the ventral capsule ventral striatum, and the other is subthalamic nucleus. There is one recent study which compared both targets. Basically, they implanted the DBS electrodes in both regions, both subthalamic nucleus and ventral capsule ventral striatum. And for 3 months, they kept subthalamic nucleus on, and 3 months, they kept ventral capsule ventral striatum on in a blinded manner, and they assessed the outcome. What they found was there was no difference in outcome between the two groups. Both groups improved OCD to a similar extent, but the ventral capsule ventral striatum improved mood to a better extent, while the subthalamic nucleus DBS improved the cognitive deficits to a better extent. So there is some evidence to say that both are equally effective, but it's a very small study with only 6 subjects. We have to keep that in mind. So what are the adverse effects of DBS? It can be divided into 3 types of adverse effects. One is complication during the surgery itself. Chances of intracerebral hemorrhage can happen because you're inserting electrodes, but the chances are quite low nowadays because with improvement in targeting, the chances are quite low. And post-operative infection, which can be sometimes seen, especially in the area where you implanted the electrodes, that is another rare side effect. And in long term, there may be depletion of battery, lead. The electrode is sometimes called as lead, and which might break. That is also another rare side effect. So these are quite rare side effects. You can say less than 5%. But the more common side effect is because of the adverse effect of stimulation itself. So depending on the area where you stimulate, there may be certain adverse effects. So various different stimulation-related adverse effects have been discussed in the literature. But the most interesting thing is the presence of mania or hypomania. This has been seen across DBS targets and across DBS conditions also. Like it has been seen in patients with OCD, it's been seen in patients with Parkinson's disease also. Sometimes across targets, DBS can cause hypomanic symptoms. And when you adjust the stimulation, the hypomania improves. Yeah. So overall, most of these side effects are quite uncommon in long term. What about the long-term effects? As I said, that most of the studies have been done on short term. There are studies which are done up to 9% of up to 9 years of follow-up also. And most of these studies have said that around 50 to 75% of patients maintain their improvement in follow-up up to for 9 years. And as I said, when you insert non-rechargeable batteries, you have to change the battery in the interim period. Yeah. So long-term improvement has been seen, and there are some cost-effective analysis which has shown that DBS is cost-effective as compared to treatment as usual also. And another interesting aspect, it has been seen that people whom CBT has failed, after giving DBS, CBT might have been found to be helpful. So CBT might be augmenting the effect of DBS. There are a few studies that have been done, but it has not been studied that systematically. So as I said, even after DBS in long term, you have to continue, most patients need to continue medications and also CBT for over long term. Yeah, I'll just briefly discuss about the guideline. There is an evidence-based guideline which says that overall in OCD, subthalamic nucleus has level 1 evidence and nucleus accumbens has level 2 evidence. And it has been safe. The ventral internal capsule DBS has FDA approval for severe treatment refractory OCD. Yeah. So yeah, this is a brief slide comparing meta-analysis comparing DBS versus ablative surgery, which is more effective. Generally, there are no direct head-to-head comparison trials. This is a comparison trial compiling all studies with DBS and all studies with surgery. And what they found was they used a measure called as utility, where they combined the uh, efficacy and adverse effect into a single measure. So a treatment with higher utility is found to be more useful. Overall, the study found that ablative surgery has slightly more utility compared to DBS. So, but since these are not head-to-head trials, we had to be a bit careful interpreting these results. But the important thing is that ablative surgery, we cannot throw away ablative surgery. Even after the advent of DBS, they also might be useful in a subset of patients. So that is a major take-home message from this particular study. So with this, I'll go to the next disorder, that is major depressive disorder. Yeah, in major depressive disorder, DBS has been attempted in 3 primary targets. This is the primary target is subcallosal cingulate, BA25. This was done by Helen Mayberg and colleagues from US. What they found, this particular region, subcallosal cingulate, has been found to be hyperactive in people, even in people with major depressive disorders. And this hyperactivity decreases following various antidepressant treatment, including antidepressant medication, CBT, and RTMS. And so they started studying whether stimulating this particular region directly, whether it will be helpful in the treatment for DBS. That is one particular target. The second commonly used target is ventral capsule, ventral striatum. This is the same target used in OCD. And this is based on the hypothesis that frontostriatal circuitry has been implicated in the pathogenesis of depression also. And capsulotomy, which targets the internal capsule, has been found to be effective in depression. So this is another target that is commonly used. And the third, more recent target, medial forebrain bundle. This is done by a German group, where medial forebrain bundle is a particular part. It's a white matter structure which carries the orbitofrontal thalamic fibers, and it contains the fibers carrying the reward pathway. So whether stimulating this pathway might be helpful, there are a few studies available. So these are 3 different targets that have been done, studied. But most of the studies have been done on either subcallosal cingulate or the ventral capsule, ventral striatum. The subcallosal cingulate is the part of the cingulate cortex below the corpus callosum. So there are some specific criteria for DBS for any surgical treatments for depression also. As I said, the major thing, you can go into this is given in the Indian Psychiatric Society guidelines. Basically, patients should have chronic, severe, and treatment refractory depressive disorder. That is the overall gist of the criteria. So I'll not be going into the individual studies. This is a meta-analysis which compared which compared various sham control trials in DBS, and this meta-analysis found that they compiled studies on internal capsule, subcallosal cingulate, and also medial forebrain bundle. Overall, DBS was found to be effective as compared to placebo. So if this particular diamond, if it touches the line or if it goes to the left of the line, it is found to be, it is said that it is not effective. And if it's to the right of the line, it is effective. So overall, the evidence says that DBS is found to be effective. So, but still, if you see, it is more for medial forebrain bundle and less for the subcallosal cingulate touches the line, and rather for internal capsule, it rather crosses the line also. So it means that there is some variability in results, and it's a bit questionable. And one of the main reason for that is that there are 2 relatively large trials. These are industry-sponsored trials. These are done by companies which have been manufacturing DBS electrodes. They did large trials, one on subcallosal cingulate and another on ventral capsule, ventral striatum, called as the Broaden trial and the Reclaim trial. And in these trials, these were sham control trials. both these trials had to be stopped before in the interim period, because they did an interim analysis and they found that the active arm was not different from sham arm. They did a more complicated analysis. I'll not go into the details, but it was found that the trial was not showing any promising results. So based on which they felt that there's no point in continuing these trials, and they stopped both the trials. So based on this, there have been questions raised whether DBS is really effective in depression or not. But proponents of DBS have given various reasons for these inconsistent trials. One of the important thing is that in both these trials, because it's when you're doing an RCT, you will not be able to change the stimulation as required. So you had to use a particular stimulation that has been set by the trial. So you're not able to flexibly change the stimulation. That is one particular aspect of it. And the patients, they say that the patients were not followed enough for longer period might be required. But whatever the reason, these two trials have raised some questions. So people have started looking again into whether DBS is effective or not. And another important development of all these things is that people have said that probably we are not targeting it properly. And so people have started looking at alternative ways of targeting DBS in OCD. So, DBS in depression. So based on this, we can say that although the earlier meta-analysis have been found to be helpful, the recent studies have raised some questions. So even now, the results in DBS for depression is inconsistent. So yeah, now I'll briefly discuss about Tourette syndrome DBS, because this is another psychiatric disorder for which there is some evidence. There are three commonly used targets. One is particular thalamic nucleus, another is globus pallidus interna, another is the same ventral capsule ventral striatum as we used in the other two disorders. Overall, there are some RCTs also, and there are systematic reviews. All these reviews say that DBS has been found to be helpful in Tourette syndrome in any of these targets. So but all these studies are of very small sample size, like 5 subjects or 6 subjects. So we have to take it with a pinch of salt. Large scale studies are not yet available. So Tourette syndrome also, we can say there is emerging evidence to say that DBS is effective. So I'll go to vagus nerve stimulation from DBS. So yeah, this is vagus nerve stimulation. In DBS, you insert the electrodes into the brain. Vagus nerve stimulation, the electrodes are inserted into the vagus nerve, especially on the left vagus nerve. Around the carotid sheath, it's inserted. So, and this electrode is connected to the same into another battery, which gives continuous stimulation. It is inserted into the left node because inserting it to the right node the right vagus has connections with the SA node, and that might cause some cardiac side effects, because of which it's primarily inserted to the left side of the brain. So how does vagus nerve stimulation work? Probably the vagus nerve has both afferent and efferent fibers. The afferent fibers probably transmit to various parts of the brain, particularly to the nucleus tractus solitarius, and from that to various parts of the brain. And through that modulation, it might cause some changes in the brain. It was originally studied for treatment-resistant epilepsy, but when VNS was given in epilepsy, it was found that patients improved in their mood symptoms independent of their anticonvulsant effect. So the seizures didn't improve, but mood improved in quite a few patients. So because of which that studies were done in DBS, of VNS in depression primarily, and there has been FDA approval also has been given for VNS as an adjunctive treatment for chronic or recurrent resistant depression after failure of at least 4 antidepressant treatments. 4 antidepressant treatments includes antidepressant medications, CBT, and electroconvulsive therapy. So I'll be briefly discussing about the evidence. There is only one proper randomized control trial available, and that is a negative study. It was a large study. It was 235 patients, and the study found that 15% of the active VNS group improved compared to 10%. The difference was not significant. So this was a negative trial, and despite that, the FDA gave approval. One of the main reason is that this is a short-term trial. This trial was done for a period of up to 10 weeks. And people said that probably DBS doesn't help in short term. So VNS doesn't help in short term. You need a longer stimulation. So they said that you may have to continue stimulation for 6 to 12 months. So people started gathering evidence, other forms of evidence. This is one particular study, this particular study led to the FDA approval, where 205 patients with vagus nerve stimulation plus treatment as usual were compared with treatment as usual alone. But mind, this is not a controlled trial. Basically, this was an independent sample, open label trial, and this was a totally independent sample. And both the groups are followed up to a period of 1 year. And they found that VNS led to a greater improvement compared to the treatment as usual group alone. But after 1 year, the response rate, that is 50% reduction in HAM-D scores, was seen in 27% in patients with VNS. So that doesn't seem to be very great, but still, for a treatment-resistant population, this might be helpful. A more recent study was done a 5-year follow-up, which says that around to 70% of patients have shown improvement. So overall, this is also an uncontrolled trial. This is also a non-randomized trial. So overall, we can say that there is no evidence from randomized controlled trials, but through other sort of non-randomized controlled trial evidence, we have some evidence to say that vagus nerve stimulation might be helpful in a subset of people. But still, but overall, the interest in VNS have decreased over time for two reasons. One, people have started because of the failure of the acute trials, and also people have started showing more interest in DBS. And another aspect is that now we have a cutaneous, like transcutaneous way, non-invasive way of stimulating the vagus nerve, which is called as transcutaneous VNS, which is being studied. So there is more interest in that aspect compared to the invasive VNS for OCD, for depression. Yeah, so yeah, these are the adverse effect of vagus nerve stimulation. As like in DBS, in VNS, there are surgical complications that can happen rarely, like infection, pain. These are rare side effects. Transient vocal cord paralysis has been found to occur in a few people, which resolves in a few weeks. Asystole has been found to be quite rare, but it can occur. So these are immediate surgery-related complications. Asystole primarily occurs due to two reasons. One is because of anesthesia, and also because you're stimulating the vagus nerve. These are rare side effects. The more common side effects are stimulation-related. Since you're stimulating the vagus nerve, a lot of local side effects like hoarseness of voice. This is the most common side effect seen in 50 to 70% of patients. Cough, dyspnea, dysphagia, nausea, vomiting. All these things can be seen. And most of these side effects usually decrease with time by themselves, or if you decrease the stimulation parameters, they decrease. And as in any other psychiatric antidepressant treatment, hypomania or mania can be seen in a few people, and that decreases on adjusting the stimulation parameters. So with this, I'll conclude. To summarize, DBS is a promising treatment for treatment-resistant psychiatric disorders, especially for OCD and Tourette syndrome. There is some inconsistent evidence for major depressive disorder. VNS, it has not been found to be helpful in short-term studies, but long-term studies have shown some efficacy. Thank you.
Thank you for your presentation, sir. Now the floor is open for discussion. So, the question asked by her is that what is your personal experience with DBS and VNS in your practice?
So yeah, we have till now we had primarily used surgery mainly for OCD, and we have generally done ablative surgery. DBS, we have done one surgery for Tourette syndrome. We have not done any DBS for psychiatric disorder in immense as yet. And as I said, we are going to start it now.
Your experience about intractable schizophrenia and DBS in intractable schizophrenia, is it of any help?
Okay, in schizophrenia, generally, surgery is not recommended for schizophrenia. There is only one recent study that has been done, but overall, there is no evidence for any of these surgical techniques for schizophrenia. So yeah, so generally for ablative surgeries also, previously when it was used, it has been found that people with depression and OCD improve better compared to schizophrenia and psychotic disorders. So we don't have much evidence.
Dr. Nishad has asked, is there any evidence for cognitive improvement in VNS?
Okay. Overall, in most surgical techniques, it has been found that there is an improvement as the symptoms improve. There's a few studies have found that cognitive functions seem to be better post-surgery also, 3 to 6 months. Earlier, ablative surgery is used to report of cognitive deficits, but more recent studies, including DBS and VNS, have found that maybe like the neurocognitive functions might improve post-surgery.
Any contraindications for VNS?
Contraindications for VNS, any contraindications for surgery, primarily because it's a surgical technique. It's generally done under general anesthesia. So that is one contraindication. And cardiac issues might be a contraindication because you're targeting the vagus nerve. And the general contraindication for surgery, primarily, might be a contraindication.
So I have a doubt that when we are talking about VNS, because it is both afferent and different, we are stimulating, taking into mind that it'll affect only the brain. There will be also downward effects.
Yeah. So one way to do it is that, like when you stimulate the vagus nerve, you place there is a positive contact and negative contact. So you keep place the positive contact and negative contact in such a way so that only the afferent fibers are stimulated. Just leads to the afferent stimulation goes up rather than comes down. That is one way of doing it. And generally, the afferent effects have not been found to be that much in vagus nerve stimulation.
Dr. Swati has asked, what is the role of artificial intelligence in DBS?
So nothing in particular, sir, in adjustment of the pulse waves and stimulation, whether artificial intelligence can be used or whether manual adjustment needs to be done.
As of now, we are doing manual adjustment. Generally, manual adjustment is being done. Still, no, artificial intelligence has not been employed for that particular aspect because you have to test it in a trial and error method, and you might have adverse effects also. So it's generally being done in a manual method.
Dr. Praveen has asked, is DBS should be continued for lifelong, or can it be stopped after the symptoms are relieved?
These patients are, when you use DBS, you are using in chronic patients and treatment refractory patients. So if the improvement occurs, you probably this it's because of DBS. So if you switch off, it has been seen that when DBS switches off or the battery gets over, many patients relapse. So generally, it's a long-term treatment. As of now, as I said, people have studied up to 9 years or up to 9 years, and most of them had to continue their DBS.
What Dr. Divya has asked as to what are the basic assessments done before these procedures?
So before these procedures, like any surgical treatment, you have to get routine investigations done. But apart from that, there are a few things that is given in the Indian Psychiatric Society guidelines how to go about it. But basically, you have to, for all surgical treatments, one is confirmation of diagnosis and make sure that the patient meets the criteria for treatment refractoriness. And most centers have the patient assessed by an independent committee. We have a committee of an independent psychiatrists, 2 independent psychiatrists, 1 neurologist and neurosurgeon, who are not affiliated to NIMHANS. They go through all the patients, and only if they say yes, then the patient goes ahead for surgery. So that is one important thing. And obviously, you'll be doing a neuroimaging to see whether there is any lesion in the brain or and neuropsych assessment has to be done to look into pre-post changes. So these are the common assessments that are done before surgery.
So Dr. Sagar has asked, what are all the referral centers for these procedures?
Referral centers in India, if you ask, few centers are doing DBS. We have started in NIMHANS, we are going to start now. And there are a few other centers that are doing DBS. As far as I know, Jaslok Hospital in Mumbai does it. And I'm not sure, in Delhi, one center has done it. And these are published evidence. And recently, I think Apollo in Chennai also has done one surgery. there are very few centers that are doing it right now.
Dr. Nishad has asked, can a person receive MRI with surgical implants?
Yeah, that's a good question. MRI, generally, it's better to avoid it. Two reasons. One is because it's a magnetic field, there may be some movement of electrodes. And second thing, because the DBS electrodes are there, it might the quality of image might be affected because of the magnetic effect. So, but there are few manufacturers which have said that they have given a conditional approval. You can take MRI under specific conditions, like you can take only a 1.5 Tesla MRI, and there are a few other conditions based on which you can based on which you can do an MRI. So you had to look into the particular manufacturer's recommendations.
Dr. Sarath, I have unmuted your mic. Can you go ahead and ask the question?
Yes, sir. Hello, sir. Sir, my doubt is, since we're talking about treatment refractory depression and deep brain stimulation, so on a later date after implanting the electrodes, if you would want to, give a trial of ECT or TMS, would it be feasible, or we don't have evidence about it?
There is evidence for ECT. You have to switch off the stimulator before giving ECT. There are a few reports that are there. You just switch both VNS and DBS. You switch off the stimulator, and then you might be able to give it with adequate precautions. Those are given in those articles. TMS, as of now, there is no evidence, but it might be a bit risky also. So till evidence, like the people are studying it, and people are studying it basically in head models actually, where they say it might be risky. So as of now, TMS, it's better to be avoided after DBS.
Dr. Divya, we have unmuted you. Can you go ahead and ask the question?
Sir, any specific predictors which we can look into to say that different procedures have different prognosis?
As of now, there are no consistent predictors. But yeah, for OCD, there is some evidence to say that maybe like people with sexual and religious obsessions might improve better. There is some evidence for that. But apart from that, there are no consistent predictors as of now.
Dr. Shashank, can you go ahead and ask the question?
Good afternoon, sir. Sir, I just want to know once if after putting the DBS stimulator, how much will it cost to the patient?
Okay. It depends on setting. In NIMANS, we charge around 5 to 6 lakhs because the stimulator costs around that. But depending on the private setting, it might differ. It may go up to 10 lakhs also for deep brain stimulation. 10 to 12 lakhs is what for the whole procedure. This is talking about the non-rechargeable ones. But if you do the rechargeable one, the price is double this.
Vishnupriya, you can go ahead and ask the question. You had raised your hand.
Yes, sir. Like, how much does it cost for a private institution to install this particular setup? Sir?
Yeah, that's what, as I said.
To have a setup. To have a setup to have deep brain stimulation.
There is no need for a particular setup actually. You need a multidisciplinary team. You need a neurosurgeon who has experience in DBS, and there should be MRI facility should be available, and there are certain equipments that are required for implanting DBS, like for there's a frame, there's a recorder, there are various things that are to be done. So these are quite expensive. So any neurosurgery setup who are doing DBS for say Parkinson's disease, which is the most common indication, will be able to do DBS for psychiatric disorders also. There's no need for any additional setup. So any neurosurgery team that is doing DBS for movement disorders can do it.
Because they would also have probably intraoperative MRI with frames.
Yeah, postoperative. Yeah, it's more about, postoperatively you might need a CT. intraoperate C-arm and those sort of things. Different, depending on setting to setting, it may differ. Depends on the neurosurgeon's preference. These sort of requirements. So finally, it's about the neurosurgeon. It's primarily a surgical procedure. It should be remembered. We are just referring the patients. The surgeon runs the show over that. Depends on his preference, his or her preference. The equipments required might differ.
Dr. Shashank has again asked the cost for every session once the stimulator has been placed.
There is no need for every session. It's a continuous stimulation. Once you insert the simulator, the battery keeps on stimulating. You just set the program. That's it. You adjust the setting in the battery. It'll keep on going. But there is one recurrent cost. As I said, if you use a non-rechargeable battery, after the battery depletes, you have to change the battery, which costs around 5 to 6 lakhs.
How long would battery run, sir?
Battery non-rechargeable. That depends. The ventral capsule, ventral striatum, it has been seen that the battery consumption is very huge. So people have said that sometimes the battery gets over in 1.5 years or 2 years. But but in subthalamic nucleus, like when I discussed with the Malays group in France, they say that their batteries last up to 5 years. So it depends on your target and how much stimulation you give. If your stimulation parameters are very high, battery depletes very fast. So anywhere between 2 to 5 years.
Dr. Divya, you can go ahead and ask the question.
Hello, sir. Sir, any specific instructions to be given? Hello?
Yeah,
Sir, any specific instructions to be given to the patient after the procedure as such, other than the adverse effect related information or the device related?
Yeah. That's very important. Actually, since this is a device in situ, you have to be very careful, especially in the acute period. You have to look for infection and sort of things. And since you have a metal in your body, and generally all these sort of instructions are given to the patients. There is when the patient goes after surgery, what you can do, what you cannot do, what are the procedures you can undergo. For example, MRI, all these sort of things are given to the patient. And another thing about surgery is also, like, some patients have a tendency to, especially people with OCD or Tourette syndrome, especially Tourette syndrome, they have a tendency to what is known as Twiddler syndrome. They have a tendency to sort of twiddle with the scar or the battery. So that is also something we have to inform the family members to keep a watch for those things, so that to minimize the chance of infection. So most of these things are done in short term. In long term, generally people are able to manage. It has been tried in people with Parkinson's disease, the cognitive deficits. Most of them, like, they are able to manage.
Dr. Bharti, you can go ahead and ask the question.
In those patients with depression where DBS has been done, have they tried RTMS by any chance? Because some in the US, some of my friends who are psychiatrists, they're actually thrilled with, RTMS being, a tool in the treatment of intractable depression.
Yeah. So as I said earlier, RTMS might, as of now, is a relative contraindication post DBS. There is no evidence. It might be a bit risky to give RTMS. So till we get further evidence, it's better to avoid that. We don't know whether it is safe to give or not.
Before, sir?
Before, okay, you want to know whether RTMS it can be tried, but overall, if you see the response rate to RTMS and most studies that have been done, in people with who have failed with one antidepressant failure, but one or two antidepressant failure. But DBS is one in which you give in patients for whom most other treatments have failed. So it's a completely refractory patient. RTMS has a totally different role. It's probably in slightly lesser range of resistance. But you can try before going for DBS, before going for invasive treatment. Definitely you can try RTMS before going for DBS.
Dr. Sagar has asked, will the electrodes or device be removed ever?
Even in people for whom stimulation is stopped because of adverse effects or whatever reason, some people prefer to keep the stimulation in situ, especially for VNS, because adhesions might develop around the carotid artery and sort of things. People don't remove the VNS, so it might be a long-term thing. And even for DBS, many people don't remove unless there's an infection or something. People generally keep the electrodes in situ. It's usually safe.
Is it possible to turn off the pulse generator by one's own in VNS?
not sure. I don't think it's possible. There needs to be a particular device that needs to be done to switch on or off the PNS. But currently, at least in DBS, there are some patient held programmers where some people have started using that patient himself or herself can program the DBS, especially by there are some programmers that are being given to the patients. But overall, it's generally advised to be done by the treating doctors. Okay, thank you, everyone.
Thank you, everyone, for participating, for coming and participating in the session. And we also thank Dr. Shamsundar sir for his time and effort in taking the class. Thank you, sir. Also, do subscribe to our YouTube channel, Nimhans Indians, where you can get access to all our videos. The present video will be uploaded in a couple of days. There were 31 sessions which are taken till now. So all these sessions will, the videos are available in our YouTube channel. Subscribe and watch our YouTube channel. And you can comment on the comment section if you have any questions. So we'll get back to you with the answers. We also thank Linux Laboratories Chennai for their academic grant through which we are running this program.